Good day to all, and welcome, and thank you very much for joining us today for an NTB webinar on strengthening TB surveillance. My name is Babis Ismanidis, and I will be chairing today's webinar. I work at WHO. I'm with the TB Monitoring and Evaluation and Strategic Information Unit of the Global TB Program, and I am the team lead for strengthening surveillance, epidemiological studies, and data for action. Just some housekeeping highlights. We are live streaming this webinar on the Global TB Program's YouTube channel, so please be aware of that, as well as we are recording the session, and we will be sharing the recording with you over the coming days. Please communicate with us either through the Q&A or chat buttons. Unfortunately, in the interest of time, and because there are many of you, we will not be asking people to talk. So please use the Q&A box for questions only, and please use the chat box for all other comments. The presenters and panelists will be answering questions throughout the webinar, as well as during the Q&A session at the very end of the webinar. Without further ado, I would now like to invite Dr. Teresa Kashaeva, the director of the Global TB Program at WHO here in Geneva, for her welcome and some opening remarks. Teresa, the floor is yours.
Thank you very much, Babis. Dear colleagues, partners, and friends from around the world, it's a great pleasure for me to join you today and welcome you to this NTB webinar on strengthening TB surveillance, a global synthesis of findings from national assessments 2013-2020. As you know, unfortunately, TB remains one of the world's top infectious disease killers, despite being a preventable and curable disease. The prolonged COVID-19 pandemic has caused significant disruptions to TB services, resulting in many people that fell ill with TB last year, missing out on access to care, and TB mortality being on the rise. This affects particularly, as we know, the most poor and vulnerable populations. Since the adoption of the WHO's NTB strategy and the UN Sustainable Development Goals by all member states in 2014 and 2015, high levels commitments have galvanized global, regional, and national progress towards reaching agreed targets and milestones, and it has been reinforced during the first WHO Ministerial Conference in Moscow and later on at the first ever high-level meeting on TB. To measure progress towards national and global targets for TB, countries need strong surveillance systems that allow them reliability monitor and the TB epidemics. Strong surveillance systems that produce reliable and high quality data are essential, absolutely essential to understanding the magnitude of TB burden and what impact our programmatic interventions are having. Strengthening TB surveillance systems and implementing epidemiological reviews is one of the strategic areas of work of the Global Tuberculosis Program. For nearly a decade, together with national TB programs around the world, as well as donors and technical partner agencies, WHO has been implementing national TB epidemiological reviews and surveillance assessments, according to standardized terms of references and set of global guidance and tools. Findings and lessons learned from these reviews are incredibly valuable as they identify critical gaps in surveillance, monitoring and evaluation, and data use, and allow us to define actions to raise dedicated funding to address these gaps. Attention to and dedicated investments for strengthening surveillance systems are much needed, especially in countries with weaker systems, such as those still relying on paper forms. We need to support all countries with their transition to more robust, digital, case-based, real-time surveillance systems for TB. In our very fast-changing world where we all learning lessons from COVID, we should definitely be faster, rely on strong data, and be more proactive to be able to provide adequate and timely support to people with TB with diagnosis and treatment. This webinar will start with a presentation of findings and recommendations from 130 reviews carried out between 2013 and 2020. This will be followed by an expert panel with a wide range of stakeholders who will give us their insight on the implementation, use, and impact of these reviews. We will close the webinar with the questions and answers session with you, dear colleagues, friends, and partners. I would like also to use this opportunity to thank you all for your hard and dedicated work. We know very well that you are not only focusing on TB, but also addressing the latest issues with the COVID and contributing a lot into the health system strengthening. And I would like to acknowledge, with your permission, my team unit of monitoring and evaluation, Babis Ismanidis in person and his team for really wonderful, very hard, dedicated work. I hope that it brings benefits to all of us, and as I told, first of all, to our patients. Finally, I wish you a very constructive, informative, and successful webinar.
Thank you very much, Teresa, for these words. Let us now continue. Let us continue with the main presentation of the webinar on the subject of strengthening TB surveillance, a global synthesis of national assessments 2013-2020. This will be a presentation given jointly by myself, Mari Bartens, and Marek Lally. Next slide, please. I will start with a brief background on the WHO Global Task Force on TB impact measurements and national TB epidemiological reviews and surveillance assessments. Next slide, please. In recognition of the importance of data generation, it's the previous slide, Maria. Thank you. Yeah. In recognition of the importance of data generation, data use, and measuring the impact of global efforts to reduce and ultimately end tuberculosis, in June 2006, the Global TB Program established a Global Task Force on TB impact measurement with its monitoring, evaluation, and strategic information unit acting as a secretariat. The task force includes a wide range of experts in TB epidemiology, statistics, and modeling, representatives from major technical and financial partners, as well as representatives from high priority and high burden countries. Next slide, please. The initial aim of the task force was to ensure that WHO's assessment of the 2015 Millennium Development Goals and associated global targets was as rigorous, robust, and consensus-based as possible. Following that, in the post-2015 era, and in the context of the NTB strategy and the Sustainable Development Goals, the task force reviewed and updated its mandate and strategic areas of work. The mandate was expanded to also include the guidance, promotion, and support to countries for the analysis and use of data for policy planning and programmatic action. 4 strategic areas of work were defined to accomplish this mandate, 2 of which, strengthening routine surveillance systems for TB and the use of the data that they produce, I will be focusing on today. Next slide, please. The National TB Epidemiological Review is a cornerstone activity for these two strategic areas of work. An epidemiological review is essentially a process that is led by independent experts at the invitation of the country and in close collaboration with the National TB Program. It typically takes about 4 weeks to complete a review with a preparatory phase, an in-country mission, and a report production phase. It involves a desk review of all relevant documents, forms, and reports. It involves interviews with all stakeholders, data collation, data analysis, and data interpretation. In order to promote standardization across countries, we have developed terms of reference, an implementation guide, a recommended analysis handbook, a DHIS2 platform with standard analytical dashboards to facilitate the analysis, as well as we have conducted multiple global, regional, and national trainings of experts involved in these reviews. Finally, there are 6 objectives of these reviews, ranging from assessing the quality and coverage of the TB surveillance system using the WHO TB checklist, and I will explain that later, to carrying out a series of analytical tasks to assess the level and trends of TB burden. There are also objectives promoting the ownership of findings from national TB programs, promoting the data use and interpretation, and finally, capacity building of national teams. Next slide, please. National TB epidemiological reviews are promoting multi-sectoral collaboration, very much in line with WHO's multi-sectoral accountability framework for TB, as well as data systems interoperability. Multi-sectoral collaboration is promoted by engaging and visiting with different types of stakeholders that either provide TB services or impact the way TB services are delivered. This typically happens during the in-country mission. In addition to stakeholders that the national TB programs are already working with, such as, for example, the different types of health facilities that offer TB services, including private sector associations and non-governmental organizations, as well as other disease programs that could be caring for people with TB, we put extra effort to widen the circle of relevant stakeholders that TB programs should be engaging with in order to strengthen TB surveillance. Some examples include the Health Management Information System departments, the National Bureau of Statistics that is typically responsible for vital registration systems in the national census, as well as departments responsible for example, for primary health care, the National Health Insurance, correctional services, the labor department, mineral resources, and the list goes on. Now, in an effort to increase the coverage of the national TB surveillance system, epidemiological reviews are also promoting the interoperability and linkage of different data systems that hold information on people with TB, but are not necessarily linked with or reporting into the official TB surveillance system. Examples include the National Reference Laboratory Network database, the National Database of Notifiable Diseases, the Health Insurance Database, and the Hospital Associations database. Next slide, please. Epidemiological reviews are essentially a dynamic process that can be repeated every few years. We typically start with assessing the status of the routine surveillance system for TB. We analyze and use TB and other relevant data to identify gaps in surveillance, M&E, and data use. And we then come up with recommendations and an associated investment plan to address those gaps and to inform policy planning and programmatic actions. Typical examples of processes that are informed by epidemiological reviews include the development of national strategic plans, program reviews, and domestic and international resource allocation concept notes. Next slide, please. As I have already explained, one of the objectives of the National TB Epidemiological Review is to assess the surveillance system for TB. We do this by using the WHO TB surveillance checklist of standards and benchmarks, which was developed to assess the quality, coverage, and accuracy of the national TB surveillance system, to identify gaps and to recommend solutions associated with specific activities. The checklist has two parts. The first providing a standardized description of the surveillance system based on key characteristics of the system. And the second part comprises a series of 13 in total standards with associated benchmarks. Standards are essentially dimensions of the surveillance system, the general statements about the characteristics of a high-performing TV surveillance system, while the associated benchmarks provide the evidence that defines, in quantitative terms where possible, the level of performance that the system under evaluation is operating. So based on this evidence, the standard is considered to be met or partially met or not met, or in some cases not applicable. See, for example, on the right part of the screen, standard B1.3. So the standard states that all scheduled periodic data submissions have been received and processed at the national level. The associated benchmark is defined as 100% of all expected reports from each of the TB basic management units in a country have been received at the national level. Now, if the findings show that the level is indeed 100%, then that standard is met. If it's less than 100%, but more than 50%, it is partially met. Less than 50%, it is not met. So this is just an example of how each of the 13 standards are expressed. Now, out of a total 13 standards, 7 relate to data quality, 2 to system coverage, 1 to the quality and coverage of the vital registration system as a way to accurately measure TB mortality, and 1 standard each relates to 3 key subpopulations of people with TB. That is, people with drug-resistant TB, people co-infected with TB and HIV, and childhood TB. Next slide, please. Now over to Marie for some results.
Thank you very much, Babis. I'm Marie, and I have the pleasure to present to you today the status of implementation, key findings, and lessons learned from this global synthesis of national TB epidemiological reviews and TB surveillance assessment from January 2013 until April 2020. Let me start by giving an overview of the status. Since 2013, TB-specific epidemiological reviews, including TB surveillance assessment, as they are, and Babis explained this just now, they're typically part of epidemiological reviews. They've been carried out in all regions of the world, as you can see here on the map, covering 81 countries in total. Of these, 50 countries have carried out a review between 2018 and 2020, and overall 41 countries have carried out multiple reviews. As mentioned before, we are presenting today findings from reviews with results available as of April 2020. However, it is important to mention that the work did not stop as the COVID-19 pandemic started. In fact, an additional 6 countries carried out reviews during the rest of 2020, and 2 countries have carried out reviews so far this year in 2021. The majority of them were carried out in a full virtual format. It is to note that the strongest supporters of these reviews have been the Global Fund and USAID. Now I'd like to present you a summary of results from the most recent TB surveillance assessment carried out in the 29 of the 30 high TB burden countries by using the part B of the WHO checklist of standards and benchmarks for TB surveillance that Babis has just introduced you to. The results are presented here by standards, and I'd like to walk you through them in a bit more detail now. If you focus initially on those first data quality standards, which are the first 7 ones within the 13 dimensions of the checklist, we can observe the following. You see at the beginning that there's an impressive standardization and consistency in the case definitions that are used and the type of the data that is collected according to WHO guidance. Each of these 2 standards here was met by 27 countries. However, the completeness of reporting up to the national level still requires improvement. We can see here that the periodic transmission of data and quarterly reports upstream, meaning from district to province or from province to national level, was only complete in 10 countries, while in an additional 12 countries, it was only partially complete, meaning that less than 100% of reports have been received, and in 7 countries, it was not even able to measure. The next 2 standards concern the transition to digital case-based surveillance from paper-based system. And as you can see here, this really remains a key priority, as less than half of the high TB burden countries have either partially or fully accomplished this transition. Even in countries with digital surveillance system, which is the standards 1.5, there remain issues with the quality, accuracy, and completeness of data. The following two and the last two of the data quality standards are considering consistency. Standard 6 is externally consistent and was more often met than the internal consistency, standard 7. Moving on to the coverage, we actually see that there's really significant gaps with the coverage of TB surveillance system. We have only one country that met the standards that all diagnosed TB cases were reported. And only 6 countries, this is standard 1.9, met the standard related to good overall access to healthcare, while all other countries did not meet this standard. The National Vital Registration System, in short VR, is also an area of concern. We have only 2 countries that had a national VR system of high quality and coverage. And then looking at the 3 supplementary standards that cover drug resistance, HIV infection among TB patients, and childhood TB, we can see that drug-resistant TB surveillance was of high quality in nearly half of the countries, and for HIV infection among TB patients of high quality in more than half of the countries. Lastly, and this is another point that requires attention, we see that the surveillance of childhood TB was only met by 1 country, and that the vast majority of countries did not meet the standard. This is really indicating that there's problems relating to the diagnosis and the reporting of children with TB. I have to say, we're showing here the results from the high TB burden countries, but obviously we also assessed the non-high TB burden countries, and the results in these 52 countries revealed a very similar picture. There are only some differences in the first 4 data quality standards, considering the percentage with which the standards have been met. In the next step, we have also quantified the performance of national TB surveillance systems for all 81 countries that were assessed with the checklist by applying a scoring system, which is shown here at the bottom right, where every standard that was met got 3 points. For partially met, we assigned 1 point. If a standard was not met, we actually subtracted a point, and for standards that were not applicable or not assessed, we gave 0 points. We have applied this to all standards, the scoring system, but as you have seen on the last slide, there are challenges with the coverage. So what I would like to show you here is a summary of the summary scores based on the 7 data quality standards. And these are really under the direct remit of national TB programs. What you can see is here that overall the majority of countries partially meet the data quality standards, though only around 15% meet the majority of them. In contrast, around 20% of the countries do not meet, not even partially, most of the data quality standards. It's really indicating that the data quality within the surveillance system in these countries is insufficient and needs further attention. As mentioned before, 41 countries have conducted repeat assessments. Of these, 19 are the high TB burden countries, and among all of them, 8 have conducted 3 assessments as of April 2020. And you can see this here represented on the global map, split by the high TB burden and non-high TB burden countries. Now, why are repeat assessments, especially with the checklist, useful? Well, they can be used to assess whether recommendations that have been made during a previous assessment have been implemented to improve unmet or partially met standards, but they also allow us to monitor where the standards that had previously been met have been maintained. So we applied the scoring system to repeat assessments as well, and that really allows us to quantify how much countries have strengthened or maintained their surveillance systems capacity. And of the 41 countries that have conducted a repeat assessment, 30 made a net improvement. There was no change in 5 countries and a worsening in 6 countries. The latter really triggers a follow-up with countries, and we're trying then to identify underlying reasons for this deterioration and offer support. But here it is also very important to note that worsening does not necessarily mean that the surveillance system overall becomes worse or weaker. This can also mean that major changes have been introduced to the system. And I will elaborate on that a little bit more in a minute. Now, I would like to look at the findings in a bit more detail by the individual standards, as shown here among the 19 of the high TB burden countries that carried out a repeat assessment. It is important to note that some of the standards can be more easily improved than others, especially those under the remit of the National TB Program. If we consider the main findings, we can summarize that the standardization of case definitions and data collected according to WHO guidance, which are the first ones again, they remain consistently high, and they even showed a lot of further improvements. There is strong improvement, but also some volatility in the completeness of data reporting, which is standard 1.3, and in the internal consistency 1.7. And reason for the volatility is that some countries are in a transitioning phase from this paper-based to a digital system. And I'm going to talk about this a bit more in a second as well. Then we're seeing few improvements in the transition from paper to digital case-based surveillance, where gaps really remain at large. This is the standard. And there were some improvement and consistency in the performance of drug-resistant surveillance. This is standard 2.1, and in the coverage of HIV testing among TB patients, 2.2. Lastly, there was very little improvement in the overall coverage of the surveillance system, which is 1.8, and the overall population access to healthcare, 1.9, and the quality and coverage of the vital registration system. And importantly, again, the accurate diagnosis of childhood TB, particularly among the very young children, remains a priority area. Also to note here that repeat assessments among the non-high TB burden countries, again, showed a broadly similar picture. Now I'd like to present to you an example from one country that used the checklist and carried out reviews and assessments multiple times. This country is Indonesia. You can see here that 3 assessments were carried out in Indonesia, one in 2013, one in 2017, and one in 2019. And this really allows the country to monitor progress towards strengthening TB surveillance. Now, these results really make a great impact because the results from these epidemiological reviews have been used in 2 full program reviews. They've also informed the development of a 5-year national strategic plan for TB, and also multiple funding applications that really resulted in millions of US dollars allocated exclusively for surveillance, M&E, and data use. At the level of the standards that is shown here in the table, we can observe a slow but steady progress in the country. Not visible in the table, but considering the progress more in depth, we can also remark major advances when looking at the recommendations that have been addressed and the activities that have been completed. And we know this from our epidemiological reviews in the country. So this also applies to standards 1.9 and 1.10 when it comes to coverage. We can see actually little progress in the table. They're all still in red. But these standards are not under the direct remit of the NTP. And knowing from our last epidemiological review in the country, it really became evident that some progress has been made when trying to address these standards. So important links between different departments of the Ministry of Health and the national program have been established to really move this agenda forward of improving access to care and strengthening the vital registration system. And finally, the analytical capacity of national and provincial teams for TB data has greatly improved with the use of digital platforms and associated analytical dashboards. So we really see a great impact following these assessments. As you can see, there are several messages that clearly emerge from the synthesis of TB surveillance assessment to date. And based on these 8 years of experience that we have now in 81 countries, I'd like to share with you a little bit of a summary of what we've just heard. So what we can see is that the checklist of standards and benchmarks has been really successful in achieving its aim of assessing the performance of national TB surveillance in a clear and standardized way, while also being able to identify the gaps that need to be addressed. The results from these assessments have really informed the development of many national investment frameworks for TB, resulting in millions of US dollars in domestic and international funding that have been exclusively allocated for strengthening national TB surveillance system, but also for the implementation of some complementary studies, such as prevalence surveys or inventory studies. Overall, for about half of the standards under the remit of national programs, there have been demonstrable improvements and high levels of consistency. This is especially true for the data quality standards for DR, drug-resistant surveillance, HIV testing of TB patients, and the mandatory notification of TB cases. And these improvements can be attributed to clear policy changes that are instituted by the national programs, leading to effective and prompt actions. However, there are still clear gaps in data reporting and completeness. And as I mentioned before, these are primarily related to the transition from aggregated paper to case-based digital surveillance. So what happens is that when digital systems are first introduced, there will be some problems with data quality and completeness. This is almost to be expected. Until then, the country has the necessary capacity and expertise in terms of IT and data analysis, and this capacity has been built at all levels in the country. And then related to this previous point, even when there's a clear commitment to strengthen TB surveillance and making demonstrable progress, it is not always possible to make a rapid or directly measurable improvements. There's often a bit of a lag between the conceptualization and the implementation of interventions that were designed to address any gaps. And there's then another lag before we can really observe changes. And this particularly applies to standards that involve stakeholders from multiple health or disease programs. And then we have two standards not directly under the purview of the NTPs that are related to good overall population access to healthcare and vital registration systems. And these really require engagement across the health sector and beyond, and are that way a bit more challenging and complex to address. And lastly, and an important point, that the surveillance of childhood TB so far has seen minimal to no improvement in nearly all countries, really indicating that there's an urgent need for more commitment and effort to engage with all of the stakeholders concerning maternal and child health in countries. And that concludes my part, and I would like to hand over to my colleague Marek to take over.
Thank you, Marie, and good day to everybody. So in the last section, Marie showed us some of the key findings from the standards and benchmarks assessments that have been carried out globally, including which of the dimensions countries are performing well in, as well as some of the gaps identified. So in this next section, we're going to look at the synthesis of the recommendations that were made to countries in order to address these gaps. Next slide, please. For this synthesis, we developed a framework of high-level categories for these recommendations. We reviewed the latest report for each country and then fit the country-specific recommendations into these higher levels. The core part of the framework is presented here on the slide. I'm not going to read out all of the recommendations, but it's just important to note that it contains the dimensions that are directly linked with the standards and benchmarks assessments. So that's covering areas of improving data quality, the transition from aggregate to a case-based digital platform, addressing underreporting and underdiagnosis, which both relate to the coverage of the system. It addresses recommendations for improving vital registration systems, as well as improving the surveillance of childhood TB, TB, HIV, and drug-resistant TB. Next slide, please. We then had a separate section to look at the transition from aggregate to case-based digital platforms more closely by disaggregating this recommendation further. And we had an additional section that looked at the supplementary recommendations that came from EPI reviews, which are not necessarily directly linked to the standards and benchmarks. Next slide, please. So once we reviewed all of the reports and fit the country-specific recommendations into the framework, we then prioritized the recommendations based on the number of countries where that recommendation was made. So this slide is showing the top recommendations that have been made to address gaps that have been identified through these assessments. And these findings are really important for the TB community. They provide a very clear and systematic picture of country needs when it comes to strengthening routine TB surveillance, analysis, and use of TB data. And it also informs the direction that we need to take at the national, regional, and global levels with the development of technical products and other tools to support ministries of health in their fight against TB. Next slide, please. So here we're looking at recommendations number 1 and 6, which relate to the recording, reporting, analysis, and use of TB data. And that's to transition to or strengthen digital case-based real-time surveillance and to strengthen routine analysis and use of data at national and subnational levels. Next slide, please. And we're addressing these 2 recommendations in a few ways, as we see on the slide. First, standards have been set for data entry and for the visualization of key surveillance indicators to facilitate the analysis and interpretation and the use of these data for programmatic action. We've also been working very closely with the Global Fund and the University of Oslo on the development of WHO TB DHIS2 packages for health facility data. And as we see on the middle panel on the map, this has now been used in 52 countries. And we've also been developing a case-based DHIS2 package, which has since been piloted in a further other 4 countries, which are Ghana, Laos, PDR, Rwanda, and Tanzania. And finally, we developed supporting material for the implementation and use of these packages. This includes a guidance book for program managers, an associated exercise book, as well as a series of presentations, which we use for our capacity building activities on data analysis and use. And traditionally, these capacity building activities have been implemented through face-to-face training workshops. But we're now working on translating these material into an e-learning solution to improve outreach. Next slide, please. The next 2 recommendations we're going to discuss are related to ensuring high quality TB data. And that's to develop or review standard operating procedures or other tools for data quality and validity, as well as to strengthen routine supervision for data quality checks, including through implementing data validation workshops. Next slide, please. We're currently working on a major review of the 2013 definitions and reporting framework for TB. This is now being rebranded as the 2021 guidance on TB surveillance. And Babis is going to present a bit more on this later, but it's just important to note at this stage that this new guidance will have an expanded scope compared to previous editions and will now include a specific chapter on ensuring data are of high quality at all steps of the data recording, reporting, and use process, both in terms of the pathway to care as well as at all administrative levels. Furthermore, DHIS2 has been supporting the improvement of data quality by providing the opportunity to include automated data validation rules. And there's even a specific data quality application that's included in the package, which we're going to be working on more in the next coming months. Next slide, please. To address system coverage issues, countries were often recommended to measure the level of underreporting of diagnosed TB cases through an inventory study. Next slide, please. And for this, guidance has been produced on how to carry out a national inventory study to measure and address underreporting of TB cases. And to date, 19 countries have completed an inventory study, and a further 5 countries are either planning an inventory study or have one underway. And for the next edition of the standards and benchmarks checklist, we're going to consider alternative approaches to achieving this same objective where an inventory study is not feasible. Next slide, please. And finally, improving the availability and quality of TB mortality data may be one of the most difficult to address directly from the recommendations that we see on the list on the slide. And this relates to establishing or strengthening nationally representative civil registration and vital statistics data. We're not really talking about treatment outcomes data here. We're really talking about the CRVS. And this is a bit more complicated because it's not under the direct purview of the TB programs, as Marie mentioned earlier as well. However, as Babis did mention, we saw that EPI reviews are an opportunity to bring together other partners who play a role in TB surveillance. And in this case, we encourage strengthening the collaboration from relevant departments or ministries or offices who is responsible for civil registration and vital statistics data. Next slide, please. So that's the end of the recommendations section, and I'll hand over to Babis. Thank you.
Thanks, Marek. I would now like to walk you through the final 2 slides of this presentation that will give you a flavor on what our thoughts are with regards to next steps of this stream of work, as well as any derivative and associated products we will be developing. Next slide, please. So really the single most important direction that we will be taking is the development of a unified digital case-based real-time environment for TB surveillance. We would like to move away from situations where the focus was traditionally on case finding, just on some of the steps of the pathway of care. So primarily on case finding and primarily on treatment outcomes. We would now like to essentially be able to follow the full pathway of prevention and care of all people who are at risk of TB disease, but also TB infection. And what we would also like to do with this environment is, in addition to following all the steps of the patients, of people with TB disease and infection, we would also like to be able and collect data all along the different locations where people go and visit and where data for the same individuals are being generated. Traditionally, the focus has been the health facility. We would now like to expand that and also allow the collection and use of data at the level of the laboratory, as well as at the level of the community, the household, the workplace. And the idea there is to ensure that we really capture the information of the same individual all along the pathway, all along the different locations that the patient is visiting to receive health services, and then make sure that the data linkages are there, they're clear, they're strong, and they all seamlessly feed into a single consolidated surveillance database. Next, please. And to do that, we will be developing a fully expanded guidance on TB surveillance. We're going to be doing that this year. You've already heard some Marek and Marie refer to that, and there will probably be a dedicated webinar later on presenting the direction we're going to be taking with that. That essentially the TB surveillance is going to be addressing, just as I've presented, is going to be addressing people at risk of TB disease and infection. It will be addressing capturing information all along the pathway of prevention and care and linking information across the different location of services. What we will also be doing, you've already heard from Marek that we have developed the WHO TB DHIS2 digital packages to collect and use data at the health facility level. We're now going to develop digital packages to allow the collection and use of data also at the laboratory level, as well as the household and community level. Remember, this will all be done in a way that that all the different pieces will seamlessly be working together in a unified environment. For countries that do not want to use the HS2 systems, or they would prefer to use another software, what we are also going to be developing is a digital accelerator kit for TB. These are essentially a software agnostic set of standards for the collection, analysis, and use of data. And then finally, in order to make sure that the transition to a case-based digital system is as successful as possible, before we actually go ahead with that, we would also like to make sure that some prerequisites are in place in the country. So we have developed these terms of reference for running these national readiness assessments, that we call them, for TB surveillance. And we will be looking at things like political commitment, funding availability, levels of HR, infrastructure, and sustainability plan. And then finally, just in one sentence, really the direction with this is to avoid fragmentation of different pieces, different databases, collecting information for the same individuals, to avoid fragmentation and to avoid project-based solutions, and really come up with a unified solution that addresses all these issues. Next slide, please. What we will also be developing over the next few months is the second edition of the surveillance checklist. So the surveillance checklist needs to align with the expanded scope of the new guidance on TB surveillance. So we are currently working on that. What you have seen during this presentation is a series of figures, graphs, and maps that have taken quite a bit of time for the team to develop. Well, what we would like to do is actually facilitate this process, and to do that we will be developing essentially a global resource that will allow NTPs and partners to monitor the global status of TB surveillance, and we will be doing that through the development of a DHS2 digital package, where we will be uploading key results from all future EPI reviews, and there will be analytical dashboards that will automatically update all these figures, maps, and graphs. And then finally, and that will be for the use of countries for internal purposes, for discussions within the country, as well as with funding agencies, we will be developing an app that will be providing all the details on the national TB surveillance profile. Next slide, please. This is a slide just to say that there's three of us presenting here, but just to acknowledge that all this work is really the result of hard work from many surveillance and M&E teams of national TB programs from around the world, as well as partners both inside and outside WHO. Thank you for listening. Next slide, please, Maria. All right, so this concludes the part of the webinar that where we have gone through the results of the global synthesis. What we would now like to do is invite our panelists to provide us with their own unique perspective on TB epidemiological reviews, how they have been using these reviews, what the EPI reviews mean according to their opinion and their perspective. So to kickstart the discussion, I would first like to invite Dr. Razia Fatima. She's the Chief Research and Surveillance for the Common Unit of TB, HIV, and Malaria from Pakistan. So Dr. Razia, Pakistan is a country that has carried out 3 EPI reviews between 2014 and 2019. Please share with us your experience with carrying out these reviews and how the results have been used to guide action in the country. Over to you.
Thank you so much, Babis. And I take this opportunity to thank again the WHO headquarters, the Impact Management team, especially you, Babis, so for supporting us for over a decade now. So actually, we had 3 EPI reviews. One was in 2014, and the second was in 2016, and third one was in 2019. But we are very fortunate that when we started from 2014, it was most of these boxes which you were showing as summary for the checklist was red. But in 2019, there was significant improvement, and this was because of continuous guidance that was provided from the WHO. So thank you again for that. So in 2019, there were 6 standards that were met, and 1 was partially met, 5 were not met, and was not applicable because there was no national digital case-based surveillance system at that time. So I will just tell you a history how we are going about, and then I will tell you the current status and the way forward. So in terms of data quality, there were important improvements that were achieved with the standardization of the data collection according to the WHO guidelines. And this has led to this B1.3, which is improving to met in 2019 compared to partially met in 2016. So with 100% coverage of capture of data from paper registers into the DHIS2, this was possible only. So I remember in 2017, when we had a big mission in Pakistan with the help of University of Oslo, and you were leading it, Babis, with us. So we thought that was the time that we started thinking about this at least aggregate model for the surveillance system in the country, because previously it was all paper-based. So after that, there was an aggregate DHIS2 system that was available, and we had a national analysis and use workshop at Islamabad, which is the capital city here, and Babis was again the facilitator. So where we invited all the key personnel from the provinces, and they had actually hands-on training for this DHIS2 package or system that was actually developed by WHO, and it was the training was done to them. And with the help of University of Oslo trainings, now we have our own dashboard, and I'm sure when we will have this 2009, after this 2019, when we have another EPI review, then you will see much more improvement. So this was again because of that push. So now we are moving from the aggregate paper-based to the, again, we are now at the aggregate DHIS2, but our plans, which are just started, and again, this was because of our priority to think about the case-based notification system for TB in the country. And we had this opportunity for C19RM, which is a COVID mitigation grant that was announced by the Global Fund. So we put in this case-based surveillance system scale up, and that was fortunately approved. So again, I would say this credit goes to again WHO for helping us to think about the case-based system, and we will start it as a as a pilot soon in the Islamabad and also in all the regions. So we have a plan for our national scale up in 2022 with the same funds, and also we have a grant that we are negotiating now, which is the Gates Foundation, and we have again put in this case-based surveillance system on priority. So this is about how we are going about. Also, we have done 2 inventory studies. One was the adult inventory study, and one was the child inventory study. So both of them, they provided us with the evidence of high underreporting. So we are already thinking about this repeat TB prevalence survey in the country, which is planned very soon, because it's already a decade now when the last prevalence survey was done. So, and again, as part of the plan, I would say as part of our checklist improvements, we also are thinking about this mandatory case notification system in all the country. And we have already done a pilot in 4 districts. So this is our plan to link it with the DHIS2 tracker, and also our PPM intervention, especially the chest camp intervention, already in process of linking with the DHIS2 tracker. So we have a complete plan to go for a national case-based surveillance system scale up in the country. And we will soon be updating, and we will engage again the WHO headquarters to support us for this scale up, which is a huge undertaking for the country. Thank you.
Thank you so much, Dr. Razia, for a really fascinating overview of the work that you have been doing you have been leading in Pakistan the past few years. So clearly a country with a very strong example of how really the surveillance systems can indeed be strengthened, even under difficult and complicated conditions. So thank you so much for that, Dr. Razia. I will come back to you with questions later on. Let's move on to the next panelist. So, in fact, this is a recorded message. So, Rafael Lopez, who is the regional advisor for TB from PAHO and from the regional WHO office of the Americas, he has recorded a message outlining the regional experience with the implementation of TB epidemiological reviews and how these have contributed to the regional capacity building on analysis and use of TB data. Marie, could I please ask you to play the video?
Good morning. My name is Rafael Lopez, advisor for TB prevention, control, and elimination at the Pan American Health Organization, WHO's Regional Office for the Americas. Thank you for inviting me to this panel. Today, I would like to share with you our experience in the region of the Americas with the implementation of the TB EPI reviews. Our first EPI review was conducted in Haiti in 2017 by WHO colleagues and consultants. Since then, 7 EPI reviews have been conducted so far. In 2018, 2 were conducted in Peru and Brazil, and additional 2 in 2019 in Dominican Republic and Guatemala. In those, we involved 3 epidemiologists from countries in the region, including 1 from our PAHO WHO Collaborating Center on Epidemiology from Argentina. There was increasing interest in countries on this exercise, so we decided with our colleagues in Geneva to conduct a 5-day consultant workshop in July 2019 in Colombia, where we trained 13 consultants that would support us in what we had planned to conduct in 2020. But the COVID pandemic arrived and we halted our plans. Nonetheless, discussing with our colleagues in Geneva, we decided in the second half of that year, to develop or adapt the EPI reviews methodology and agenda to a virtual platform. And that's how we ended up conducting 2 EPI reviews end of last year in Cuba and Jamaica. And then at the beginning of this year, 1 in Costa Rica. 4 more EPI reviews are still planned for the remainder of this year. And actually, next week, we will start an EPI review in El Salvador. In all of these EPI reviews from the last year, we have been involving our junior consultants who have been helping us in this exercise. So far, the benefits of these EPI reviews have been the following. For the NTPs, it has helped them to review and discuss their epidemiological situation, also to recognize their strengths and gaps in their TB surveillance systems, and to identify interventions needed for improvement. How have they used these results so far? I could summarize them in 3 points. First, to advocate for funding within their government or through donors to address the gaps that were identified. Second, to adapt and or incorporate elements of the EPI review in their routine surveillance system. And third, to plan for further studies to better understand some of the gaps that have been found. I would like to take this opportunity to thank our colleagues in WHO for helping us through this process, as it has been, the EPI reviews have become one of the activities that the regional TB team is conducting in countries. And there's increasing interest from several of our countries to conduct these exercises in the coming months and years. And we hope that next year we will be able to do it in person, not virtually. Thank you very much.
Right, there we have it. So that was the perspective from one of our regional offices. I will now like to turn to Dr. Corinne Merle, who is a scientist with WHO's special program for research and training in tropical diseases. Corinne, please talk to us about the experience of the Western and Central Africa research networks for TB with TB epidemiological reviews, how these have been used to promote the use of digital packages for TB surveillance, as well as informing research priorities. Over to you.
Thank you, Babis. Thank you for inviting me to contribute to this panel discussion. What I would like to share is the TDR experience concerning a peer review, especially in the West and Central Africa region, and how it can feed or be used for defining research objective and conducting operational research. First, I would explain that TDR is a special program at WHO where we are looking at tropical disease research. So that means that we are interested in research, but to do research, you need to understand the problem. And we started to work with the National TB Program of the West and Central Africa region 6 years ago, with the objective of boosting, enhancing operational research in this region, country-led project for addressing TB control gap. And when we started to look at the data that the country were having, that was a mess. It was Excel spreadsheet, impossible to do any trend analysis, impossible to look at sub-national indicators. And after discussing with the National TB Program Coordinator, and because of the support of the global TB team, we had a chance to use a new module that at that time the WHO Global TB was developing with the DHES2. That Babis and Marek mentioned. And that was the TB historic module that was mentioned by Marek, where all the NTP accepted to put all their historical data for the surveillance system. And we used this data in the DHES2 to train the monitoring evaluation people to better understand their data, to better understand their TB control gap, and therefore, and that was what we were interested in, defining the research priority. So that was the start of training monitoring evaluation people from the National TB Program of the West African region, 16 countries. We did the same for the Central African region. But on top of that, they were taught on the standard and benchmark analysis, how to ensure good quality data, reliable data, things that Mary touched on earlier. So these are the two big pillars of a peer review. So the next step was to try to train them on the job. And because there were a lot of peer review in the West African region, we conducted a peer review with bringing with us monitoring evaluation people from the National TB Program. So Benin, Burkina Faso, we're going to Chad, Niger, and Senegal, we're going to Togo, and so on. And so then at the end, we managed to have a pool of monitoring evaluation National TB Program people trained on EP review, better understanding their data, and therefore not only being able to conduct a peer review in the region, but also when they were looking at their own data, being able to analyze their own data and inform their National TB Program and the practice. So I think in terms of output of all that, first of all, we have people who are interested because they understand better their data, they understand their data at national level, sub-national level. And I would say that the DHES2 TB module is fantastic for that because it facilitates this type of analysis. They also understand if the data they are looking at is reliable or not because of the flow that they can detect because of the standard benchmark analysis. And we have also a group of people that can help each other because they have done a peer review in their own country. So that means that it's very positive experience, I would say. And for us, for the research aspect, we noticed that because a lot of countries have conducted this peer review and understand better the data, they have been able to develop a national TB research plan with priority of problem to address during operational research. And that's exactly what we wanted them to have and to build. And without this exercise, I think that this could not be achieved. And now you have seen that Babis was mentioning all this digital evolution that the country should go for. And there are this group of monitoring evaluation people are really ready to move forward. And there will be, some of them will be piloting the tracker module, and also I would be happy to go for digitalization of lab data and all these kind of things that Babis was mentioning. So really it enhances all the knowledge on how important good quality data is and how good quality data can be used for programmatic activity, but also for research activity for a better control of the TB. So it's very positive. That was what I wanted to share.
Thank you.
I would just finish by saying that all that TDR could do it only because also at the other side, the star were aligned. Global TB were having some objective, and we were able to work together, and it was really successful. Thank you.
Thank you very much, Corinne, for a comprehensive response. I will get back to you with any questions. So let's move on to the next panelist, So let's hear the perspective of the funding agency. So I would now like to ask Dr. Namdi Nwaneri, who is a specialist with the Technical Advice and Partnerships team at the Global Fund, to give us the Global Fund's perspective on why these activities have been consistently prioritized for funding for since 2013, really, and perhaps please give us share with us any future plans that the Global Fund has about supporting this stream of work. Namdi, over to you.
Thank you very much, Babis. Good morning, afternoon, and evening to everyone. And I'm happy to be part of this panel. I think I'll break your question in two parts. The first part, why is the Global Fund prioritizing, or why does the Global Fund prioritize these EPI reviews and surveillance assessments? I think, well, of course, beyond alignment with WHO normative guidance, the prioritization and investment in EPI reviews and surveillance assessment is kind of like a logical choice. The Global Fund is the largest external funder of TB programs globally, and it is thus imperative for us to ensure that our investments are targeted at sound interventions and activities that are proposed by countries and backed by data that are capable of driving programmatic impact. So, and the TB EPI reviews and surveillance assessment aid this process and definitely help national TB programs to understand what the most recent trend in the TB epidemic and disease burden in the country is. And in addition to that, it also assesses the status, the gaps in the countries, and what needs to be addressed with respect to national surveillance systems. So this is very important to us. And even more important is the fact that the output of this process eventually feeds into and informs national planning, such as the National Strategic Plan, the National Program Reviews, and also, more importantly, the national funding requests to the global, and the funding requests by the countries to the Global Fund. And these are usually in alignment with the National Strategic Plan. So it's kind of like a win-win situation where on one hand, the country is able to develop better quality plans that would help in the fight against TB disease. But on the other hand, for the Global Fund, we are able to invest our resources in interventions that will be able to drive progress and impact. So based on this, like over the years, the maps which have been shown here, the Global Fund has systematically worked with countries to ensure that, first of all, they have budgetary provisions in their grants to support the conduct of program reviews and EPI reviews, at least once per funding cycle, which is about 3 years, which is 3 years for the Global Fund. And this has helped the countries to improve their routine surveillance at the country level, strengthen country technical capacity, as well as the use of data for decision making. But complementary to our investment through country grants is our strong collaboration with technical partners, particularly WHO, through the Strategic Initiative on Data, to ensure that not that the required goods and tools which countries need, the technical support which they require to conduct these EPI reviews, and the capacity is built at the national level and the regional level. So this has been definitely, this synergistic effect has been definitely critical for countries and for the Global Fund to drive progress against towards supporting surveillance system strengthening. What are the future plans for the Global Fund in this work stream? So in addition to some of the things which I mentioned already, and these activities that routinely funded through country grants, and Dr. Reiser talked about the C19RM funding mechanism, which also helps to support surveillance system strengthening. I'll talk a bit about some of the specific activities which we are going to support through the strategy initiative on data. Some of them were mentioned already. The first is the building of the capacity of consultants to conduct these EPI reviews and surveillance assessments by WHO. And this is something that has been going on, and we definitely see the result, and we will continue to support this throughout this current funding cycle. In addition to that, we also WHO will also be providing technical support and assistance to countries implementing these program reviews. Marit spoke earlier about a few reviews being conducted this year despite the COVID challenge in a virtual format. And it's encouraging to see this, that countries are still able to conduct these reviews and get output or recommendations which they can use for planning and investment prioritization. We have generic 2Rs or for program reviews and EPI reviews, which we've collaborated closely with WHO to develop, and countries can actually adapt to use when they're implementing program reviews. From the slides, you would notice that some of the recurring recommendations or critical ones are from the previous surveillance assessments are that the countries need to strengthen digital case-based real-time surveillance, as well as strengthen routine analysis and use of data at country, at national, subnational level. And working with the Stop TB partnership with support from WHO, we would be conducting rapid country assessments aimed at identifying gaps and facilitating transition to real-time case-based reporting in 20 TB strategy initiative countries. This, of course, would complement the work done by WHO, where it's also implementing readiness assessments in countries. And in terms of data generation and availability, Marek and Babis already alluded to our work with WHO and University of Oslo, which is a good collaboration to ensure that the DHIS2 digital packages for case-based and aggregate data, as well as the software agnostic digital accelerator kits for TB are available for countries with the non-DHIS platform. I think it would also be good to use the opportunity to talk about the Global Fund's work on strengthening analytical capacity of disease programs and use of program data for decision making. We are working with regional technical partners and institutions in the Latin America region. We are working with PAHO to ensure that they support national programs to build this capacity and also use the data as expected more frequently, and use the output for decision making. In the East and Southern Africa region, we are also working with a consortium of institutions led by Makerere University on the same bit. It's important to say that in PAHO, this is also combined with the program reviews, which they'll be conducting alongside with EPI and impact analysis. So this combination, we think, is synergistic for the entire country surveillance system to actually work together and the output of the process to be good. I would also like to state that these achievements would not have been possible, of course, without the remarkable efforts by our national TB programs over the last couple of years, complemented by the actions and the support from our technical partners, particularly WHO, to support national programs in strengthening their surveillance systems. The Global Fund will continue to collaborate and partner with national programs and technical partners to address these identified gaps in country surveillance systems over the coming years. Thank you very much.
Thank you so much, Nandi, for a comprehensive description of the perspective of the Global Fund. This is all well taken. Let's now move to our final panelist, and let's ask a question: are epidemiological reviews only good for TB programs, or can they be translated into other disease programs? It's a pleasure to now introduce Laura Anderson, who is currently a technical officer with the Global Malaria Program. Full disclosure, Laura was part of the Global TB program early on, and she was instrumental in some of the work that you have seen presented here today. So Laura, the floor is yours.
Hey, thank you, Babis, and thanks for inviting me. It's really great to see all the progress that's ongoing in this area. So as Babis said, I've now moved to malaria, and I'm primarily leading on the development of tools to carry out surveillance assessments in malaria endemic countries. Can I just ask, Maria, are you able to project some slides? Yeah, I've just got a couple of slides because I thought it would be easier to illustrate my points. But so the global technical strategy for malaria highlighted surveillance as a core intervention. And so then there was a need to develop surveillance system assessments. And just like TB, it's a systematic approach to measuring the performance of the surveillance system and identifying and evaluating the determinants of that performance. It's recommended that all malaria endemic countries should carry out an assessment. It becomes even more important as you move towards elimination to ensure that the systems are capturing every single case, and that helps countries towards getting their certification for being malaria-free. We do believe that it should be implemented and led by national malaria programs with support from partners, because in that way the program are invested in the results and they're more likely to use the results to develop their recommendations and make sure that these are put into their national strategic plans and funded. We do recommend also that they are carried out in line with the normal sort of planning and milestones. So as part of a malaria program review, ensuring again that the recommendations go into the national strategic plan. Okay, next slide, please. So we've developed a toolkit, and it has two main features. The first is it's adaptable to the context or the burden of malaria for countries. So we have a different module for high burden countries and one for elimination. And we're also looking at surveillance of other malaria control strategies that might be carried out in the country. And then we've got a set of indicators, so kind of similar to the standards and benchmarks assessment. And the countries can choose the indicators that they want to include in the assessment. However, there's a minimum set of priority indicators that they must look at that will generate common and consistent expected outputs. And this allows us to conduct comparable and replicable assessments across multiple countries and within the same country over time. And so in that way, we'll be able to produce these wonderful maps like we have in TB. To show the progress of and improvements over time for these indicators. Next slide, please. And it's based on this assessment framework, which also similar to TB. So we're mainly looking at the performance of the surveillance system, which is defined by surveillance system coverage, data quality, and data use, and then the determinants that drive that performance. So we're interested in the information systems themselves, the minimum data that's captured, whether guidelines are being adhered to and correct documents are in place. We're interested in the tools for collecting the data flow, and we're also interested in the staff and their proficiency, if they've had training, if they're motivated, and their accountability. Okay, next slide, please. So there we have two methods. So we have a rapid assessment that takes about 4 weeks. And it's mainly focused at the national level as part of a desk review. We have a desk level tool, and it helps us to compile documents and data to look at each of the indicators. And this also involves key informant interviews with national and subnational staff where appropriate. And then we have a DQA desk level tool and we've created a dashboard in DHIS2 to look at specific data quality indicators. And this involves extracting the national level data that's available down to the lowest level, and then looking at these data quality indicators. The second part is a survey, and this is a more comprehensive assessment. And countries that want to carry this out, we're looking at 6 to 12 months to actually implement this properly. This involves service delivery DQA, so it's an in-depth data audit at service delivery points, collecting data from the primary data source and comparing it with the aggregate reports received at the national level. And we also have a question bank that has a variety of questions associated with each indicator for service delivery level, community health workers, and provincial and regional level staff. And then these field teams can carry out at the same time as the data audit questionnaires with appropriate staff. Okay, so just to say that so far we've just piloted these tools in 5 countries. I've piloted it in 1 country before COVID in Pakistan, so we don't have very many results yet. We're about to start implementing this in the GMS region, so Cambodia, Laos, Thailand, and Vietnam. So I'm quite excited about that. I don't know how it's going to work. It will be interesting to talk later, perhaps offline with Babis, how this works now when we can't travel and we can't provide that support in person, because I think that's definitely going to be a challenge, especially when we're just getting started on this. We plan to develop results similar to TB with the scorecard as well, and we're digitalizing all these tools at the moment. So we're working with a company from India who's hoping to produce something by the end of the year. Something that we don't know yet is what are the common recommendations that might come out of these reviews. I think, you know, so much work went on in TB before the team were able to identify these recommendations that are common across many countries. So I think it's going to take a few years before we can build that up. But I'm sure because the primary elements of surveillance for malaria are the same as TB, perhaps we can learn already from TB some of these recommendations, especially around the information systems themselves and the digital systems. Next slide, please. So just to finish off, can you click again? Or is maybe my little, oh, there it is. Yeah, so just to finish off to say the EPI review part has always been part of a malaria program review, and it's always been built into this planning cycle. The thing that's been new recently, and again, I know that TB has also been working on this, is the sub-operational plans and more locally tailored plans based on the recommendations that come out of these reviews. So for these high burden, high impact countries in malaria, we do malaria situation analysis, which is very similar to the EPI review, but we stratify the country into areas of low and high transmission and where current interventions are going on. Next slide, please. Last slide. And, oh, next. Yeah. And then we end up with these sort of maps where, so if you can see here, the previous strategy was just a bit, it was a bit uniform across the bottom of Burkina Faso there and Nigeria. And then following the review, we were able to make very detailed local strategic plans of which strategies should be implemented where, and then that then went to the Global Fund as a prioritized plan, and you can see that the colours are overlapping, and these are the countries that we've supported so far. So I think just to finish by saying that malaria and TB are going in the same direction by trying to digitalize a lot of the tools, etc. And it would be nice to talk more frequently, I think, on this. Yeah, thank you.
Wonderful. Thanks, Laura. This was really interesting, and we very much welcome any interaction and sort of knowledge sharing and lessons learned sharing across the different disease programs. It will be a pleasure to talk more with you about this. All right, wonderful. So this concludes the panel. I hope you have enjoyed the different perspectives that we have heard about epidemiology. What I would now like to do is invite Dr. Jaap Broekmans, who is the chair of the WHO Global Task Force on TB Impact Measurement. He's been the chair for a long time, so it's an honor to invite him to provide us with some of his thoughts now that he has had the opportunity to see this global synthesis. Jaap, over to you.
Thank you very much, Teresa. Thank you very much, Babis, for organizing this important webinar. It's, I must say, energizing that in the COVID-constrained environment, so much progress has been made on this important topic. And I talk from a long association with the history of TB control. I very much remember Chris Dye coming to me in 2005 and we discussing how we could improve surveillance. And it was because of the lack of good surveillance that we had this huge project of TB prevalence surveys in order to bring in robust data in getting a good overview of the epidemiological situation. Robust surveillance, I know from my own experience in the Netherlands, gives you the real situation and intervene. And of course, very important, monitor impact. Does it go up due to HIV? Does it go up to immigration? Does it go down due to good control? And when the surveillance system is robust, you can do away with many of the special studies. So it's like a win-win situation. I'm not at all worried that progress is slow. That's the nature of the business we are in, and we are now in a COVID-constrained environment. So progress may be even a little bit more difficult to achieve. It's as long as we are very clear on the direction that we want to go, robust surveillance. Going forward to the next task force meeting, I think it's very good to have a critical look at the existing standards and fine-tune them, perhaps add one or two, perhaps subtract one or two, because perfect is the enemy of the good. We should realize we do surveillance not to have good surveillance, but we do surveillance to improve TB control. And we should try to assess to what extent our improved surveillance indeed has led to improved TB control in countries. And I'm happy that the Global Fund was so positive on this exercise that has been carried out and presented. So for me, it's not only energizing, but it's also a very heartwarming situation in which we are now. And I wish everybody good luck with their work. Thank you, Babis.
Thank you, Jaap. That's wonderful. So I do realize that we have eaten up all time, but actually we have been responding to all questions that have been posted. So there is not a single question that remains unanswered, so I'm happy to report that. But please remember that we are available for any follow-up questions that you might have. We have an email address at the cover of the presentation that you can please feel free to use and contact us for any follow-up. We will be sending out the link to the recording of this webinar, and perhaps I will ask Teresa just for some quick closing remarks. Teresa?
So thank you very much, Babis. And of course, I can't miss this opportunity. I'd like to thank Jaap and all our colleagues from the Global Task Force for excellent work and collaboration over the years. It brings results, very important results, and for the countries, first of all. And furthermore, we can see that our investments and contribution and joint work into the strengthening surveillance system brings also results and help countries to report on the COVID situation. And this clearly shows that so-called old programs could be used for multiple purposes, and we should continue investing in the programs like TB, malaria, HIV, and others. So that's why we're so thankful about our collaboration. Special thanks to all the panelists. It was excellent discussion. The audience is staying with us all the time, more than 100 people. And this webinar will be also posted. I hope that more people will be able to see. Once again, big thanks. Marie, Marek all contributed. Our young, passionate staff will continue working, new generation. So we need more active young people joining us. So for this very important work. Babis, all colleagues, thank you once again.
Thank you very much, and thank you all. With that, I would like to close this webinar. Thank you for being with us. Bye-bye.